Welcome to Pediatric Grand Rounds. I'm Suzanne Mazer. I'm the Director of Continuing Medical Education here at Seattle Children's. And now I have the pleasure of introducing Dr. Mark Lowe, who is an attending physician in pediatric emergency medicine. He's the Medical Director of Telehealth and Digital Health at Seattle Children's Hospital. He comes to us after his PEDS residency at UCSF and his Pediatric Emergency Medicine Fellowship here at Seattle Children's and University of Washington. Lately, Dr. Lowe has been extremely busy expanding telehealth capabilities at Seattle Children's, including live and asynchronous telemedicine and remote monitoring. He's also working to evaluate and lead implementation of new digital tools and technologies that help improve patient and clinician engagement and integrate with existing hospital systems, the electronic health record, clinical practice, and research. In addition to the emergent and urgent medical care of children, he's passionate about learning how technology can be used to influence and transform pediatric healthcare, especially for those with limited access and underserved populations. So, welcome and thank you so much for being here, Dr. Mark Lowe.
Thanks, Suzanne. Thanks, everyone, for having me. I thought this topic was pretty timely, and I've got a lot of content, so I'm just going to jump right into it. I don't have any disclosures per CME, and the learning objectives. So today we're going to learn about what Seattle Children's has been doing in telehealth, the past and the present, as well as our COVID response. We like to look at telehealth critically in terms of the value of telehealth and trying to figure out if this could be something you may or may not use in your own practice. We'll hear about some predictions about where telehealth is going, especially with results to with respect to pediatric medicine. And then practically, especially for those in the community, we will talk about practical steps, how to start your own pediatric telehealth practice. So just to level set, I'd like to start with some definitions. You hear these terms telehealth and telemedicine interchangeably often. I like to use the Human Health Services definition of telehealth, which is right here, the use of electronic information and telecommunications technologies to support and promote long-distance clinical healthcare, essentially. So telehealth is more of an umbrella term, and underneath you'll hear these different things like telemedicine, which we use that term to refer to live face-to-face video conferencing. Asynchronous telehealth is what we often refer to as store and forward. So if a diagnostic test like an EKG is done at one place, it's read, and a diagnostic read is done by a provider at a different place, that is asynchronous. mHealth refers to maybe mobile apps, different apps you use to manage your own health virtually. Remote patient monitoring can be something even like glucose continuous monitor, measuring information, a wearable, and sending that information on to be diagnosed later. Then education and stuff like webinars. So all these different subsections count as telehealth, and we use the broader term telehealth. You'll hear that term in this talk. So I like to start a lot of these kinds of talks with this picture, because I think it really encapsulates a lot of what was expected of telehealth. And so this is from 1962. You may not have seen these cartoons. This is from the Jetsons, same studio that produced the Flintstones, et cetera. And essentially, you've got a sick kiddo, and the doctor is beaming in to look at him, to look at his throat. That's 1962, keep in mind. 1960 published, there are these things called comics that were published in newspapers. And so in 1960, this was a comic called Our New Age. And if you can read the little text, it basically says from thousands of miles away, a diagnosis is made by all these white-coated doctors, and the computer receives the information, helps you make the diagnosis, and spits out the prescription. So take 2 aspirin, stay in bed. Classic advice. But this is 1960, okay, Our New Age. And now we have here 2020, 60 years later. And this is our Seattle Children's ambulatory volume experience. So you can tell we've been 1%, the telehealth is in orange, and the in-person visits is in blue. So we had 1962, 1960, and now 2020. 60 years later, you see we went from about 1%, 2%, maybe 3%. And all of a sudden, there's this big spike. And surprise, surprise, we know what that is, and we'll be talking about that in just a moment. But that was our COVID-19 response to go virtual. So 82% of all ambulatory volume was virtual around April, May. And so I thought that sequence of pictures was interesting. And this is really the crux of what I want to talk about today. Does telehealth work? Because if it's that great, why does it take a pandemic to really increase our usage? And so I really want to ask that question critically. And then since we have done it, we've surged and we've responded and we've enabled virtual health. But should we continue to do it? Again, looking at it critically, how to evaluate telehealth, et cetera. And then practically, how to enable you, if you're interested in starting telehealth, to get started. So I wanted to go over the history of telehealth at Seattle Children's. So this is surprising to some, but we actually started around 2001, and this was under a grant by Sandy Meltzer at that time. And it was from HRSA, about a $3 million grant, and it enabled us to set up equipment, video conferencing, hire staff to reach out to clinics all over our WWAMI region, largely in Washington State, but just enabling us for this technology. That was pre iPhone, all of that. And it was largely through psychiatry. We're very grateful for Kathleen Myers, who just retired. We call her the godmother of pediatric telemental health. And so it really established this presence in 2001. That went on, the grant ended, but we operationalized it. And so continued doing it in a small way. In 2008, Bob Hilt and his group have set up the provider access line, the POW line. Some of you in the community may have used it. It is a critical resource for behavioral health, consult calls, med management, med reviews, and they also do telemed here in the state of Washington and also state of Wyoming. And so that is being pretty heavily used. We started piloting what we call direct-to-consumer in April 2018, and that's like home telemedicine, home telehealth. We did a very small pilot with just a couple service lines, autism, psychiatry, and Maida Chen did some with sleep medicine. And then last year, April 2019, we partnered with Swedish Issaquah, and we are doing virtual rounding, daily virtual rounding with a neonatologist offsite. In addition to these services, we also do what I was saying, asynchronous telehealth. So we do diagnostic reads for many of the pediatric patients in the region. So echoes, ECG, EKG should be combined. There are two different streams right there, and EEG. So it's fairly small. And so with these low numbers, it never really caught on here. And so the question really is why? Why did it take a pandemic, but why hasn't it taken off? I want to point you to this study that was published 2018 Pediatrics by this group called the Sprout Group. And Sprout stands for Supporting Pediatric Research on Outcomes and Utilizations in Telehealth. And it's a group of pediatricians across the country. They did a national survey that really looked at what were the barriers to telehealth adoption at their own children's hospitals, barriers to starting up a program or maintaining a program. And if you look at the far right, reimbursements really is the biggest driver, and we'll see that in a little while. Lack of provider time, lack of interest, and then regulations, licensing, all these sort of things that contribute to being a barrier to telehealth. And this rings true for our experience as well. If you don't have payment parity, if you don't have reimbursement, you're not getting paid for it, people don't really want to do it. And so in addition to the technology burdens, all of that, there are these licensing and regulatory burdens as well. This is another study that was just published a month ago, and this is looking at, again, barriers to general pediatric practice, why you haven't done telehealth. And so this was based off the presumption that in 2015, 5 years ago, the AAP came out with a statement really encouraging adoption and usage of telehealth, pointing to it as a big part of future care. But in 2016, only 15% of general pediatricians said that they had tried telehealth. And so this study was looking at why is that? What are some of the barriers? Again, the number one barrier is insufficient payments, inability to bill, cost of it, uncertainty about training and regulations as well. So again, this rings really true. These are the barriers that prevented us from really going vertical, like you saw with the COVID-19 response. And so this prevented us from really taking off. And then this happened. And so we were kind of puttering along our 1%, 2%, 3%. And as you all know, COVID-19 sort of struck us end of February, beginning of March. and we had to respond. So, in a nutshell, I can say that before COVID-19, we did very little telehealth here at Seattle Children's. It was largely these clinic to clinic visits um, where biggest users were psychiatry, autism, so the behavioral health and dermatology, endocrine also did several visits. It was um, a one-on-one experience. So provider is sitting in a room on main campus and the patient is in a room at one of our satellite clinics and they're having this conversation and doing this examination. There are a lot of federal regulations, state regulations, and even at the UW and Seattle Children's policy level, there were regulations that really prevented us from doing some types of telehealth visits. And now, with during COVID-19, since we're still in it, we did hit a peak in April, May, and as we reopen, we're seeing that peak come down. But during this time, Seattle Children's, we had to respond to really roll out home telehealth, inpatient telehealth, ambulatory clinic. It's all involved. Most specialties here have done some form of a phone visit or telehealth visit. We really moved from a one-on-one sort of experience to a team approach. So we have MAs virtually room patients, we have trainees drop in, we have ancillary services drop in. So we can really provide this full service clinic experience virtually. And many of the regulations that I mentioned have been waived. And I really can't speak enough to the changes in regulations and policy that allowed us to drive the telehealth surge. So there's a lot of them, and people have been working very tirelessly, compliance, legal, rev cycle, everybody to try to adapt to these very, very fluid times. For example, hospital credentialing used to be a 6-week process. In order to do telehealth here, you needed to go through a med exec committee 6-week process. So we did away with that, and it's just a straight training, allowing people to engage very, very rapidly. There was work at the billing level where there was enhanced payments for phone visits and payment parity for telehealth visits, video visits, and so that also made it more palatable. Washington Healthcare Authority changed some of the billing and documentation requirements, knowing that we couldn't examine patients in person. The Federation of State Medical Boards really relaxed a lot of these licensure requirements. So if you didn't have a state license in a certain state, like Idaho, for example, in our WWAMI region, before you couldn't practice telehealth there, but a lot of those state licensures were relaxed. I will say that these licensure relaxations are very, very fluid. So if you're thinking about practicing in a different state, please make sure that everything's above board in terms of if you need to get additional licensure or requirements. HIPAA, we were in such a bad state that the feds actually relaxed the enforcement of HIPAA. So things, telehealth platforms like FaceTime, for example, on the Apple platform, it's not HIPAA compliant, but they allowed it. They would relax enforcement of it during these times of COVID. Before, we never really encouraged home telehealth because there's no facility fee associated with it, et cetera. But we got to do what you got to do, and so we overlooked that, and we enabled home telehealth. Same thing with providers at home. It's something we had always wanted to do, but we never had a policy to do. Guess what? With stay at home, we had to do it, and so that was enabled. UW and Seattle Children's had a policy not to see new patients at home via telehealth. We did that too. We had to do it. And since you don't have patients being able to sign any papers, we enabled verbal consents, which was a big deal for us. As a sort of example of this, training-wise, we only had 140 total. All the history of training at Seattle Children's pre-COVID had 140. And afterwards, more than 550 have gotten trained. So we've really ramped it up. And like I said, we went from a one-on-one billing provider only model to all anyone who's facing a patient can get trained and able to do telehealth. So I wanted to show you a timeline of our COVID-19 response, as you may or may not know. So our first COVID-19 positive patient was end of February, one of our clinics. And we really didn't know at that time anything about coronavirus, this novel coronavirus. We didn't know exactly how it was spread. We didn't know infectivity, how deadly it was. We had a lot of stories out there, but we didn't have a ton of data. And so the first response by our institution was to really try to engage telehealth inpatient in our own shop. So this is something that we had never done before. A lot of other places Telehealth is really looking like you're reaching out to other community hospitals, et cetera, but we actually used it internally. And the two reasons were because we were trying to prevent provider exposure. So we didn't know exactly how infectious it was, and so we wanted to prevent people going into the room if possible. And the second one was that we knew that we did not have high supplies of personal protective equipment, of PPE. And so the second thing was we were trying to minimize and preserve PPE. So we used our outpatient telehealth carts and we brought it in-house that first week of March. Shortly after, we started doing teleresuscitation in the emergency departments. And then after we got inpatient all squared away, we started looking at ambulatory. We paused all the new scheduling. Everyone was staying at home. We did a trial of these different platforms and went with a vendor called Zoom. And that we pivoted off our pilot DTC platform onto Zoom all within 2-3 weeks, which was really incredibly fast. And then we started rolling out, hitting about 80% of normal volume in May, and then reopening June, July, and here we are now. So this is just a picture of what it looks like for the inpatients. On the right side, we've got a cart inside a NICU room. On the outside, you've got providers who don't have to use PPE, don't have to go into the room, but still able to provide these services. This is just pictures of what we built and what we used. We called it virtual protective equipment, VPE, not PPE. And we got a couple quick publications out of it. Rachel Morin from NICU, American Journal of Perinatology describes this, and Ashley Kellman from the Emergency Department, BMJ Simulation, also published this. And so after inpatient, you saw this graph before. This is the pivot to home for ambulatory, and we saw a huge spike in that. So we talked about why it took a pandemic to increase usage, the barriers, the regulations, all those things had to come down in order for us to really rise up in our visits. And so that leads us to the question, okay, we did it, we responded, we surged. Should we continue to do it? Is this viable as a long-term strategy? And how do we look at the value of telehealth? And I wanted to talk a little bit about some frameworks. So in 2017, the Human Health Services, the HHS, tasked the National Quality Forum to come up with a way to evaluate telehealth. And they came up with these domains and subdomains. And honestly speaking, the subdomains, the metrics are not super specific, but they give us rough guidelines. In order to really evaluate any kind of quality, we need these metrics. And so the main domains were access to care, financial impact or cost, experience for provider patient, and effectiveness. And if this sounds familiar or looks familiar, it is, because this is essentially the quadruple aim. And so the quadruple aim is the IHI, the Institute for Healthcare Improvements. It's their framework they use to evaluate high quality healthcare and high value healthcare in America. And so again, it's better outcomes, sort of quality, lowering costs, improved patient experience, improved clinician experience. And I wanted to use this framework to really evaluate telehealth, to look at the value of it for whether or not we should continue. In addition to this, I also would like to talk about some of the risk for telehealth and equity issues in telehealth after that. So we'll look through some of the literature that point to how to evaluate telehealth and is it valuable or not. So just starting off with quality and improved outcomes. And so there's a lot of literature, especially in the surgical realm, actually around telehealth and the outpatient telehealth experience. I've listed some of the references here, but essentially it's been shown to be very valuable, especially actually intra-op for telementoring or precepting, giving advice. There have been some studies looking at the surgical clinic wait times, duration of visit, much improved, better than in person. Of note, this was with a block schedule where the surgeons all made a whole morning or half day of virtual, and they thought that the wait times were much better and the visits ran more smoothly. Quality of interaction was much improved. There's this one study that actually said that there's a survey to the patients that felt that the quality of interaction was 2x better than in person, which is kind of interesting, but they reported that out. Same thing with post-op visits, where it was just a wound check or surgical site check. They felt the quality was equivalent, if not better. And then really triaging appropriately, especially if patients are coming from distance, something that could be evaluated virtually. Do you need surgery or not? That question was answered. And in our own Seattle Children's experience, I know that some of our surgical specialties were also able to do pre-op visits and surgical triage visits virtually, which is pretty impressive considering you don't have a in-person physical exam. So high quality for surgical specialties doing telehealth. For resuscitation, Jen Feng over at Mayo is doing some really interesting work looking at virtual quality of virtual resuscitation in the neonatology field. And so this study was published in Lancet and resuscitation, and really looked at a survey for resuscitation quality with and without a virtual neonatologist there. And unsurprisingly, the quality metrics were much improved, and sort of the steps followed, process outcomes were improved when you had a virtual neonatologist there during a tough delivery. And certainly, speaking for some of the community providers, I imagine, who have to cover newborn nursery and cover deliveries, having backup is very reassuring, even if it's virtual, I would imagine. And so it has been shown that having virtual presence there during resuscitation does improve outcomes. In the ICU and ED setting, especially in the adult ICU, there's a fair amount of literature on just showing how access to critical care specialties can really improve outcomes, including decreasing mortality, improving the process of care outcomes, decreasing length of stay. Those are all really looked at. UC Davis, the pediatric ICU at UC Davis, has put out a bunch of literature on also improving triage capability for the PICU. The idea is that if you involve the PICU provider sooner in care, like in community emergency departments, et cetera, you can get better triage. You can stick to ICU guidelines more closely, and ultimately have better quality, better outcomes. It rings true also with the emergency department. There's definitely some studies out there that show decreased door-to-doc times when virtual is used, and also transfer out to a higher level of care if you have a virtual specialist there. Safety, so we certainly want telehealth care in pediatrics to be safe, and that's sort of a factor of quality as well. And so this was an interesting study out of Israel that looked at these two components of diagnosis appropriateness and decision reasonableness. And they looked at, it was a retrospective study, they looked at a lot of these about 350 virtual urgent care visits, and they did a double-blind evaluation where other doctors looked at how reasonable was this decision to go to the ER, not go to the ER? How close was this diagnosis to what, quote unquote, I would have done? And so it had pretty decent sensitivity and specificity, and they used that to conclude that telehealth care could be as safe as in person. The second study was a school-based study looking at claims data between medically complex, sort of our MCC population, and those who were not medically complex, and essentially just looked at their utilization rates as well as their sort of acute visit rates in person, and found it to be equivalent for that population. And so they came out with the conclusion that telehealth care is basically comparable to in-person care when it comes to evaluating whether or not these patients should be going into the ED. This paper came out last year and stirred up a little bit of controversy. It was great. This is from Kristen Ray out in Pittsburgh. And what she did is she looked at the claims data for these third-party virtual urgent care vendors. A lot of them are run by family medicine doctors or emergency medicine doctors. And so what they found essentially is for the pediatric patients with acute respiratory illness, the antibiotic prescription rates was higher in these virtual visits than in person or in urgent care. And so antibiotic usage and antibiotic stewardship is a measure of quality and outcomes. And so this was suggesting that maybe virtual visits, the quality is not that great. And there was a lot of responses. This was published in Pediatrics, and there were a bunch of letters to the editor, some saying, yes, this is why virtual shouldn't be replacing in person. And others were saying, yes, this is why pediatricians should be doing this and not family practice and emergency medicine docs. But it's great. It again shows the value of doing research in this area. So those were several studies on quality and outcomes. Wanted to talk about cost, and intuitively, I think costs. Telehealth improves costs, it lowers costs. And so there have been many papers that look at this as well. The idea is that if you're using less clinic space, less clinic staff, traveling less, you'll be able to save some money. And telehealth really, if you look at how it's operationalized and how it is in the literature, it's really most powerful from a cost savings perspective in these value-based care organizations where you're trying to just really save money. I find it hard to say that telehealth is a big revenue generator, but it definitely has a lot of power in saving costs. And so, these studies show this, especially in critical care ICU settings as well. If you can, like we were talking about before with the quality, if you can get an ICU or PICU evaluation early on, that ends up decreasing length of stay in the PICU, perhaps avoiding the PICU entirely. And so that is savings to the system for sure. If you think about the example of, say, we've got a kid in Alaska with a complex a medical condition that is well known by our specialists here, but really may look pretty sick to the providers up in Alaska who are maybe meeting them for the first time. If you could get virtual and say with our cardiologist or specialist down here and say, this kid actually looks like this all the time. This is baseline or maybe even good for this kid. And if you can avoid that transfer down from Alaska, you can imagine how much money that would save the system. Another example is something like G-tube surgeries. So the gastric tube surgeries, it's a very expensive endeavor, and it's not because of the difficulty of surgery or operating room time or anything like that. It's because every time if something goes wrong with one of those G-tubes, they come back to the emergency department, and that just adds up, racking up the cost to the system. And so something like virtual could potentially avoid that, where if you can troubleshoot and maybe go through sort of like a guided process at home virtually, you might be able to avoid that ED visit, and that would save the system cost. So again, this makes intuitive sense, but there's a lot of literature out there that definitely supports this conclusion. And another kind of cost is environmental cost. And so this is something that is being looked at and we're looking at. And so on the left, this was a smaller study out of Detroit, I think less than 100 patients, with 150 encounters, and they basically looked at time saved, miles saved, gasoline saved. On the right side is out of UC Davis. Over a couple of years, it was about 19,000 visits, and they aggregate saved about 5.3 million miles, which is a lot. And again, that leads to a emissions reduction in carbon dioxide, which was significant. And so I just wanted to show you, we are also tracking that here at Seattle Children's. You can see the trend, again, the 1% to 3% before COVID, and really as we moved more virtual, we've saved about 5.5 million miles for our patients, and that's just in a couple months, honestly. It saves provider time, that providers don't have to fly out to some of these places, and that you lose half a day of clinic or a full day of clinic just trying to get out there. And then over 2,000 metric tons of carbon dioxide emissions are prevented, and we did some back of the envelope math for tree equivalents. This also shows you some geography of where we serve, and so largely the WWAMI region. Again, talking about cost, this was actually one of my favorite studies. It's out of California, the CalPERS retirement community. And so it's about 300,000 patients were looked at over about 2 years. And this brought up the concept that even though each telehealth visit could be cheaper because of reimbursement or whatnot, those patients actually might need more visits. And so the end result was that the utilization was still higher. And so we didn't get that sort of substitution where I did virtual and therefore I don't have to go in person. They didn't see that as an outcome. And so this was looking at an acute respiratory illness and whether or not telehealth would save money. And so what ended up happening was that even though each individual visit was cheaper, much cheaper, you see it was $79 versus an ED visit is $1,700. Each visit was less, but there were more of them essentially. And some of the other conclusions that they're coming up with is that because there's no physical exam, because there's more uncertainty about what the patient is like, that more testing was ordered. And so these patients who had a cheaper visit actually got more testing. And so there was a net increase in spending for something like an upper respiratory infection for this telehealth cohort. I like this study just because it really showed that um, sometimes in order to you think it's cost saving and it's very valuable um, because it costs less individually for each individual visit, but on the whole, it actually is adding more. We're seeing this in a lot of pediatric centers where for care coordination, in order to take care of these complex kids, in order to avoid an ED visit or hospitalization, it actually requires a lot of touches virtually, just checking in with them, maybe once a week, in some places like once every couple of days, making sure they're okay, and trying to really head off stuff at the pass, trying to make sure that um, that if there is a problem brewing, you take care of it early and avoid that more costly hospitalization later. And finally, just a word on regulations. I talked about how fluid they were and how they're changing. So this quote comes out of CMS regulations, and so I also talked about how facility fees were not being, because the patient's not on a facility, so you're not charging a facility fee. Well, CMS has actually came out with language, really talking about these home telehealth visits and being able to assess a small facility fee, counting it as like a hospital outpatient clinic. And so I just want to bring this up because part of the cost savings really comes from the fact that there isn't payment parity and telehealth visits do cost less. But once you start adding in all these different things, the question is, will we just equilibrate the cost? And so I thought that was sort of an interesting thought about where we're going. Moving on, we talked about quality and cost, now talking about the patient experience. And again, this, if you've ever been on the receiving end of a virtual visits, this is also pretty intuitive in terms of patients love it, families love it. It saves them time. So there's definitely literature that supports this, but even intuitively thinking about it, it saves you time. You have to take less time off work, so that's good. Uh, Daycare these days is always a mixed bag because a lot of daycares are closed, but you don't have to pull kids out of school or daycare for this. You don't have to look for daycare for other kids. You can do these home telehealth visits. You're saving fuel costs, transportation costs if you're coming from far. You don't have to drive for an hour or 2 hours or 5 hours like some of our patients do from the WAMI region to get to us in Seattle. And that means taking off time off work, et cetera. I mentioned some of the surgical studies. There was a randomized control trial for virtual follow-up versus not virtual follow-up. 95% of the patients reported that they were very satisfied with virtual versus 56% in-person surgical. So they like it. One less bill, again, no facility charge, excuse me, is a good thing for patients. And so they liked that. There's some study I just saw in these COVID times, if given a chance to do virtual, like 78% of all comers are willing to try. And so there is high satisfaction with it. If you have a family member or another person who wanted to be at the visit, but maybe they live far away or couldn't make it in time, you can join them virtually very easily. One of the papers had this quote I thought was kind of funny. The patient was saying, you're sitting in your room on your computer. How much more convenient can it be? And you don't even have to take a shower. You can get on the computer, talk to the doctor, and then go back to bed. And that's true. That encapsulates it. It's kind of what we're doing right now, I suppose. But patients do like it. Another area that we were thinking that patients would not be okay with was just getting bad news. And before COVID, this was a big no-no because you lose so much of the nuances of an in-person visit. And so getting bad news via video was really something we wanted to avoid. Unfortunately, in these COVID-19 times, you see about it in the lay press, you read about it, and you've heard stories, but I mean, there's a lot of bad news being delivered, sort of end-of-life care, et cetera, via video. And so we've been forced into this situation, and it's happening. Here at Seattle Children's, our sort of patient experience scores, our family experience scores were high, especially in the height of COVID season. And so 91% in April was our peak, and it's drifting down compared to average about 82, 83% for non-telehealth. And it's drifting down. You'll see it in the comments here. And so our feedback from for telehealth, especially in the beginning, very grateful to have something, to be able to connect to my specialist, to be able to continue my visits even from home. A lot of people were very impressed with it and liked it. We were able to provide some palliative care services remotely, which was really, really important. And then as time went on, people got more comfortable with telehealth, getting used to it. You start seeing, well, maybe there's some security concerns. You might have heard of this concept called Zoom bombing in the press. The waiting rooms, the virtual waiting rooms, getting crowded. I'm waiting longer for my visits. Technical, always, internet, computers, like there's all this technical troubleshooting, hard to connect for sure. Scheduling can be difficult, not working right. And then interestingly, and I don't know if you've experienced this in your own telehealth practices, but there's increasing intolerance to wait. And so in person, if they're waiting, maybe they got some magazines to read back when we had magazines and toys for kids to play with in the waiting rooms. But they made the effort to get there, and even if they're going to wait an hour or something, they're not leaving. What we're finding virtually is that even if it's 15, 20 minutes, even if it's in the patient's home, they just don't want to wait. And so that's something that we have seen. In the same way, late cancels and no-show rates, you would think that it would be really intuitive that I'm reaching them at their home. They should not be late. They should not cancel on us. But actually, what we're finding is that it's dependent on the service and dependent on the patient, of course. But it's not as low as we had originally thought. And what we're thinking is that maybe people are used to doing an online booking for like a restaurant back when we could go to restaurants, but they book online and they don't think twice about canceling last minute, or I'm not going to make that reservation. I'm not even going to show up. And we're thinking maybe that's the same phenomenon that's happening with virtual telehealth. And then also we're calling them up at the appointed time and they're driving, or I'm at Safeway or something like that. And so there are all these little nuances that that are part of the patient experience that are we're trying to understand how to best serve them. So moving on from the patient experience to the provider experience, there are a lot of questions here, and there's not a lot of good data. That's why I've left all these question marks. So there's some thought that potentially this could decrease burnout of providers if they don't have to travel. Maybe these visits are more on time if there's a block schedule, there are less no-shows. Again, it's a maybe, but some studies, some of the literature supports that. Maybe these visits could be shorter. From our own Seattle Children's experience, it's gone both ways. Some are very efficient and they get it all done in 10 minutes or so, and others take longer. They have to juggle more with the technology, et cetera. So it's a mixed bag. I will point out this one study for provider experience. They surveyed patients and coordinators and providers. And patients and coordinators were enthusiastic, very enthusiastic about the telehealth experience, the visits, and providers were a little bit more neutral. I will point out that providers do not think that telehealth allows you to see more patients, and they do not prefer telehealth visits over in-person visits. So again, the provider experience is a little bit more neutral. This is a graph of our specialties. So before COVID, we had about 7 specialties who were engaged in telehealth, plus minus, maybe 3. And now over 50 specialties have been able to try it out, at least. And we're grateful for all of the providers at Seattle Children's who have tried to really be flexible with us and try something that before they had not done. So we talked about some of the literature and really looking at that framework, the quadruple aim, what's the value of telehealth. I just want to speak a little bit about some of the risk of telehealth as well as equity issues. So what are the risks in telehealth? And so everyone wants to know, can I get sued? If you're starting off a practice, one thing that you really want to check on is your malpractice insurance. So there should be a specific clause for telehealth. And other than that, it's really the same as an in-person visit. The same factors that would lead you to get, hopefully not, but if you were to be sued, in an in-person visit, it's the same thing with virtual. And so There have been some lawsuits and stuff in the literature about neglect, especially in the jailed population, prisoners feeling like they're not getting the same level of care as in person. There's been some lawsuits around scope of care, people practicing virtually, doing something that they never would do in person. There's been some fraud, especially when it comes to uh, prescribing some of the durable medical equipment for patients that don't need it. And licensing, if you're practicing in a state that you don't have a medical license in, this is all pre-COVID, that was a big no-no, and there were lawsuits around that. As I was saying, with COVID-19, there's a lot of regulatory uncertainty right now, and there's a lot of fluidity. We were literally changing the guidelines weekly, if not daily. And so there continues to be this churn about what's going to stick and not stick. And so there is some risk in trying to pursue one way and not keeping up to date. And no, now the regulations have changed. There's some risk in pursuing this quote unquote new model of care. And I say quotes because we're going back to home visits or house calls. And so part of that is, for example, if we're doing a home telehealth visit, we have insight into that patient's home, and it's actually made a difference for some of our specialties like feeding clinic or nutrition, where you really can start seeing some of the social determinants of health when you can see the background, see them at home. And so that's really been able to, we're able to customize our care. But at the same time, we're mandated reporters. And so what you see in that background, you have to really consider, we're obligated to report some of that stuff too. So that's a risk. And then if the patient is looking at you and you're in your home, in your background, there's also that idea of what are you projecting and professionalism, et cetera. Also in the literature, informed consent is a really big deal and raises a lot of legal flags. And the reason why is because I think it's really important that patients understand that there are limitations to telehealth and what you can do. And so if they think that what they're going to get out of this telehealth visit is exactly the same as an in-person, they would be wrong. And so there have been some threats of lawsuit. Just I didn't know that, and no one told me that, and so we have this outcome. So I think informed consent is always raised as a flag by national sort of telehealth legal leaders. Prescribing controlled substances over telehealth. This was also a big no-no. They passed something called the Ryan Hate Act, and that is actually under review to try to relax that. Under COVID-19 times, that is actually being relaxed, and DEA has a electronic prescription of controlled substances whole pathway that you can find on the DEA website. And then, like everything in technology, there are security, privacy, fraud issues. I could tell you some stories about providers doing a telehealth visit to a patient's home, and unbeknownst to that provider, they're being recorded by another party, or there's someone else in the room that they didn't know. And so there's all this stuff that, if it was an in-person visit in your clinic room, you would immediately recognize. But because we're limited to this little tiny camera on a computer screen, and we don't have 360-degree awareness, we miss out on that. And so there are these security concerns that are continuing with this new model. So moving on from risk, I want to talk a little bit about equity and the digital divide, which we talk about the gap between the haves and haves not, essentially. And so this slide is from advisory board, but if you didn't know, a lot of Americans don't have high-speed internet, which telehealth needs to do a good visit. If you look at income, those who make less money have less telehealth visits. And we see this gap. Even on Monday, there was a pair of research letters were published in JAMA Internal Medicine talking about, it was adults, internal medicine. So adults, 1 in 4 Medicare patients are not ready for telehealth. And then another one was 38% of Medicare patients over 65 cannot do telehealth. So we know it's an issue. And right after COVID, UCSF published this in New England Journal Catalyst, just really looking at before and after telemedicine implementation, where they saw their non-Hispanic whites population that was using telehealth increase, and their payer mix also changing. So they're taking less Medicaid and Medicare, which is concerning. And so more studies like this are being published in telehealth, which is really important. And I wanted you all to know that we are also tracking this here at Seattle Children's, very similar to to that UCSF study. So I just set in the date, COVID ending today. But essentially, this gives you an overall snapshot of where we sit. This is as a whole. So individual service lines or clinics may have a different disparity, but this is just for Seattle Children's as a whole. And so you can see that we're up a tick from 88 to 89% for English speaking. Our payer mix, Medicaid is from 41% came down to 40%. And interestingly, we didn't see an increase in commercial. But this is something that we are tracking, and that is really important to us. And regarding the digital divide, I also wanted to share what we're doing in response, because we are trying to really close this gap as best we can. So one of the good things about video visits is that we're able to integrate interpretation. And so it's on demand. We can connect to video interpreters as well as phone. We offer closed captioning, ASL, etc. We're partnering with OBCC, Odessa Brown Community Clinic right now to set up these self-serve kiosks. So people without the technology or internet can just drop by and engage in their telehealth visits. We're trying to plan and form a digital health equity group that goes beyond just telehealth, but things like patient portal, etc. We're partnering with other experts. Suzine, Pat Gorstein over at UW Harborview is leading a national telehealth equity movement, and we're trying to get her expertise to help and engage us. And our own Julie Povic and the Community Health and Engagement Program here at Seattle Children's, we're calling first-time telehealth users, trying to make sure that they know how to connect, make sure there aren't any barriers there. We applied for and received funds, so we're planning to tackle these three areas. We're a loaner program for devices, for the technology, hotspots, broadband for internet, and then we're recording these videos in different languages to show how to get on the telehealth visit, how to use the portal. And so we've talked about all these different things about the barriers to telehealth, evaluating it critically, and now practically, how would you get started if you want to do telehealth? So AAP does have a lot of great information. I stole this screenshot from their page. There is a necessary use for telehealth during COVID-19, and many of you in the community may have used it already. We really still think that the pediatrician, the PCP office is the medical home and coordinate care and really be the touch point for patients. Asynchronous telehealth is something where the PCP can send off a referral to a specialist. The specialist can review it, get it back to the PCP using these virtual technologies, and still be the point of care. And the PCP can be the point of care for the patient and avoid waiting months for a dermatology appointment, for example, or the cost of that. So I think there are a lot of opportunities there partnering with the PCPs. And again, like I said, the public health emergency necessitates a lot of PCP offices to do telehealth. I know the Washington Healthcare Authority enables Zoom licenses, for example, to do it. This is a local survey done by one of our senior residents, Dr. Bollinger, and so it just showed some of the different areas surveyed, and the highest visit type usage by telehealth was the chronic condition, this idea of the medical home, and then barriers were seen as digital literacy and equipment and language, top three. So how do you get trained? So just so you know, the governor actually just signed a requirement. So starting January 2021, if you want to do telehealth, there has to be some formal training. I think a lot of us are trying to figure out how to enable this. At Seattle Children's, we have our own program, but those in the community, there are going to be free resources. The Washington State Telehealth Collaborative does have this process in flight. And so this talk should be made available to you afterwards, but there are a bunch of resources that you can use. I would like to point out the Washington State Telehealth Collaborative, as well as the TRC, the Telehealth Resource Center. So these are federally funded free resources. Ours is the Northwest Region TRC, the NRTRC. Look there. AMA has a free playbook that you can look at, and then AAP, like I said, has a whole section with great checklists and learning pearls. I just want to plug this one series that's ongoing right now. It's free and it's put on by the Human Health Services, federally funded. So it is the Telemedicine Hack series, and you can look at these different topics that may be of interest to you. You can just search for HHS Telemedicine Hack, and that will be a good starting point. So in conclusion, sort of talking about what we've learned and where the future is heading, So it's here to stay. Horses out of the barn, genies out of the bottle. It's an expectation now for the patients and providers. We are looking financially. The payment parity is going to be attainable. Telehealth is not great for every pediatric subspecialty, but it is for a lot of them. And then we're seeing new challenges and inequities arise. We need to be aware of that. My personal sort of telehealth prediction post-COVID, if we get there, when we get there. So we're going to start seeing the shift back to in person. That's what we're already seeing. But I'm really hoping that we stay above that 3% level. Really hoping for more of a 30% level. We'll see. We'll see how that goes with stay at home, et cetera. We will start narrowing down what works for telehealth and what doesn't. You know, before we just did big bang, everyone did telehealth, but we realized that it's not great for everybody. And so we'll prioritize those service lines where it makes sense. We'll start thinking about visits beyond the office hours. So especially with kids at home or school, remote learning, stuff like that, maybe there'll be a shift towards evening visits, home visits, maybe talking with families after the kids have gone to bed, etc. Same scheduling changes. We've always tried to get multidisciplinary everything. Everyone sort of descends on the patient since they took the trouble to come here for this one visit. But maybe with telehealth, we can fragment that and break it up since we're just visiting their home at different times. Hybrid model where maybe you do the visit virtually, but then the lab draws in person or the EKG is done in person. So a hybrid model. Now that we have specialists who are more familiar with virtual inpatient consultations, it's just a simple step to beam out to a community hospital and do those inpatient consults as well. And then continuing to see legislative reform. I think that a lot of what we've seen will stick. And even right now, going through the Senate, there are all these proposals to make it stick. We'll see what happens. Just the future. So, telehealth really takes geography out of the equation. How you get your care, where you do research, you're not really limited anymore by geography. If you want to reach out to a center of excellence, you can do that. If you want to reach globally, you can do that too. We talked about office hours not being a limiting factor. Having telehealth in schools is the way forward, and the expectation of patients and families. So interestingly, the latest data shows average age of the first-time mom in America is 26 years old. And so if you had a patient, a newborn patient right now, that mom was born in probably 1994. So again, digital familiarity with technology, video conferencing through a phone, that's all native to our families. So we need to adjust to that as well. A little bit more out there, but virtual hospitals, so they're at home, but you're hospitalizing them virtually, taking care of them virtually. Surgery, using those robots, that's kind of out there. And then wearable data, some pictures of stuff that exists right now. You may have even seen in your offices. I've actually seen this in the emergency department, all three of these. Okay, so should we do it? And honestly, we can't not do it. I mean, operationally here for Seattle Children's, we serve a regional center. We serve a huge population. We have to do it. We have to have some familiarity with it. We know that it has some advantages for some conditions. We're in the middle of a pandemic. We need to prepare for it. We know that reimbursement will come along, and then the technology will continue to advance, and expectations will continue to advance. And we really want to make a strong push for advocacy for the equity issues as well as the regulation issues, and then just really trying to push pediatric telehealth research as well. This, if you remember, 1970s, Mikey likes it. So he didn't think he would like the cereal. He tried it and he loved it. So hopefully our providers can also try it and like it as well. I just really want to thank those providers who really were flexible and adapting to trying out telehealth. Really appreciate it. Thanks to the IT teams, RevCycle, compliance, legal, operations, all of the leadership here that sort of helped us to accommodate the surge in telehealth.